Yeah. So good morning, everyone, and a very warm welcome to this webinar, which forms part of the Early Career Researcher Forum webinar series. So these are relatively small group events that allow colleagues to share their research and expertise on research topics of interest to our networks, and it also provides a space for discussion in a supportive environment. So these webinars are recorded and are available on the Palliative Hub. And these recordings are actually shared widely and they often have a large number of views over time. So today's question and answer session will not be recorded. And if you would like to enable captions, please do so at the bottom of your screen. So just some housekeeping rules. Please keep yourselves on mute during the presentation. Rename yourselves so that everyone can see your name. Turn your camera off for the presentation, please. And if you need assistance, we will help you. Questions will be answered at the end of today's session, but feel free to put your questions into the chat at any point. You can also use the raise hand function to speak during the discussion later on. So we are joined today by Dr. Kumaresan Cithambaram. He has 15 years of experience as a nurse in intellectual disability services, providing support to individuals with varying levels of care needs, including palliative care for those with intellectual disabilities. His research focuses on the palliative and end-of-life care needs of people with intellectual abilities, and he is currently a lecturer at the Technological University of the Shannon, Athlone, and Vice Chair of the ECRF Steering Committee. So over to you now, Kumar.
Okay, thank you, Stephanie. Thank you. Thank you for the lovely introduction. Thank you. Good morning, everyone. I am delighted to be here today, and I welcome you all to this webinar. Thank you, Stephanie, and thank you, Jane, for organizing the event. And also thank you, both of you, for a wonderful promotion. And also, finally, I want to thank ECRF and AIIHPC for giving me this opportunity to share my experience. So next 30 to 40 minutes, I am going to talk about the palliative and end-of-life care needs of people with intellectual disabilities. And if you anyone have a questions, or maybe if you have an experience that you want to share with us, please do so by using the chat function. Okay, why we need to understand, what is important of understanding the needs of people with intellectual disabilities? People with intellectual disabilities are living longer. Because they are living longer, they experience chronic conditions and life-limiting illness as same as everyone else. For example, leukemia is highly prevalent among people with intellectual disabilities and Down syndrome. And there is a high incidence of colon cancer in people with intellectual disabilities. That means people with intellectual disabilities requires a similar healthcare needs, including palliative care need, as everyone else. However, the evidence shows that there is an inequality exists in accessing health services, including palliative care. There are many instances of delayed diagnosis of life-limiting illness among people with intellectual disabilities that leads there's a lesser lifespan between the diagnosis of life-limiting illness and time of death. That leads the shorter lifespan, that shorter time between the diagnosis and death prevents the timely intervention that include appropriate palliative care. In addition, professionals working in intellectual disabilities, there lacks training and expertise in providing palliative care, and also a lack of training and expertise of professionals working in other care settings in identifying and meeting the needs of people with intellectual disabilities further complicated the process of providing appropriate palliative care services for people with intellectual disabilities, leading to suboptimal symptom control and poor quality of life in their final days. Further, more and more people with intellectual disabilities are living in the community due to social care model of service delivery and also social inclusion movement. So wherever the settings you are going to work, you are going to see more and more people with intellectual disabilities with life-limiting illness. So it is important that you need to understand the palliative care needs of people with intellectual disabilities. So I used a constructivist grounded theory approach to collect the data to explore the needs of people with intellectual disabilities and family members. So I included 11 I spoke to 11 participants with mild and moderate intellectual disabilities and 8 family members. Just I want to let you know that the 11 participants with intellectual disabilities I spoke with were not receiving the palliative care that the time that I interviewed, but they had experience of witnessing their friends or their cohabitants receiving palliative care. And also the 6 out of 8 family members, their loved ones died due to life-limiting illness. They were receiving palliative care at the time of death. The study was approved, they got an ethical approval, and I used interviews as a data collection approach. There was no problem in collecting data from people with mild intellectual disabilities. They were very articulative, and they recorded less prompts and less cues, and they could be able to recall their experience. They engage in a good conversation. But whereas people with moderate intellectual disability, really, they struggled to articulate the needs, and also they struggled to recall their experience. So that's why I use Am I Going to Die book. That is a story. If you are not familiarized with this book, the book is a story of a person with learning disabilities receiving a palliative care. That's heaviest journey of a person, the time of the diagnosis until the death. That is a very good resource for anybody undertaking a research with people with intellectual disability on death and dying. I would highly recommend this book to use for facilitate your conversation or discussion with the people with intellectual disabilities. I used a constant comparison method to analyze the data. So what people with intellectual disabilities and the family members want is the number one is this personal attention. Most people with intellectual disabilities and family members, they acknowledge that they need a personal attention, close supervision of carers. They acknowledge that they're going to be physical and emotionally fragile. They depend on carers for meeting their physical needs, not only meeting the physical needs, and also to facilitate their social needs, because they feel that they're going to be wheelchair bound or maybe depend on the transport, so they need a support of carers to facilitate the socialization. And also they felt that they need a close supervision to ensure their safety, and also they feel that they're going to be emotionally fragile and emotionally distressed. So they need a support and reassurance from the professional carers. So the next one is the social connectedness. Most people with intellectual disabilities I spoke with, they wanted to be socialized with their friends. They want to share their memories, have a fun, they have a chat, and the meaningful relationship, meaningful conversation with their friends. They don't want to break it during the palliative and end of life care phase. They want to keep going. They want to socialize. So that's another expectation from people with intellectual disabilities. Then spiritual reconciliation. And most people, nearly 9 people out of 11 people with intellectual disabilities I spoke with, they are religious. They attend the church every week. They felt, that's not only to pray, that's an social event. They can be able to meet their friends, and also they connect with the external world. And also, in addition, they thought the spiritual care provides a peace and comfort at the end. And also they will expect the prayers from the friends, family members, and carers. They feel that this is a medium to reconcile with God, friends, and family members. They maintain routine. They want to maintain a routine at the end of life, during the palliative and end of life care phase. They want to continue, that they want to maintain the normals. They don't want to break anything, because they want to continue what they have been doing for a long time. They want to attend the day services. They want to attend the workshop. They want to engage in activities that already they engaged with. Some people they help with the gardening. Some people they help in the kitchen. Some people they help in classrooms. They want to keep doing it. So that they felt that that gives them a sense of control and independence. And even they wanted to watch football or maybe watching soap or whatever they like, they wanted to keep doing it. As a familiarity, this is about the where they wanted to be cared and where they wanted to die. They want to maintain the familiarity. They want to be in the environment and surroundings where they wanted to be in, so they felt that the familiar surroundings provide a safe environment. And also they felt that familiar carers provide a better care than unfamiliar carers. They feel that, when they be with familiar carers, they feel the familiar carers that can understand their needs by observing the nonverbal cues. So they felt that they can provide a better care. And also they wanted to be with their friends at the end of life, that from the familiar environment that promote the closeness of their friends. So communication is the other aspect, the communication, the people they wanted to know about the diagnosis. The people with intellectual disability, they want to know about what's happening to them. They want to have an open communication with the professionals. If they don't know what's happening to them, it causes anxiety and frustration. So they want to know what's happening. But some of the family members I spoke with, that they don't want to disclose the information to their loved ones. They want to protect them. They don't want to upset them or don't want to hurt them. So they want to keep the information with themselves. Just I want to share a story with you in relation to the importance of communication and disclosure. Yeah, a few years back, I was working as a nurse in a residential service. His name is John, is a pseudonym. He was 65 at the time. His family was very much involved in his care. He was 65 at the time. He was diagnosed with colon cancer. His family was not happy. They were adamant that this information should not be passed to John. But the MDT have a dilemma whether to tell John or not about this news. And finally, they decided to respect the wishes of family members, so they don't want to tell the news to John. But the MDT told the parents that, in case if John asks for his diagnosis, we cannot lie, we have to tell him. So a few days back, after a few days, John, he approached the staff. He asked the staff, look, I feel tired. I am sick. I could not do what normally I do. So he was persistent, but he was persistent about what's happening to him. So eventually the staff had to tell him about his diagnosis and what's happening. So he became upset and he was crying and he blaming the staff and he couldn't take it well. So we involved a psychologist and a speech and language therapist to work with him. So a few days back, after a few days, he accepted his diagnosis and he came to terms. And he started to talk about his bucket list. So he loved Man United and he wanted to watch a live match and he wanted to stay in a five-star hotel. So two staff went with him to Manchester and he watched the match and he stayed in the hotel for 3 nights. He came back and he was happy. And a few months later, he passed away. So why I'm sharing the story is it's okay to tell the person with intellectual disabilities about their diagnosis. Once they know, they can make their wishes. Because John know what's happening to him, he could able to do what he loved to do before he died. So it's okay to tell the people with intellectual disabilities. But the most people, they're afraid to tell people with intellectual disabilities about the bad news is most people, they don't know how to support them. They don't know how to react to the reaction. So that's why most people, they don't want to disclose it. So we need to establish a system to support a person with intellectual disabilities to cope with the diagnosis, cope with bad news. So most people, they talk about making a plan and making the wish list, but they did not talk about the advanced care plan, but they spoke about they wanted to disclose their wishes and disclose the preferences. They want to write it down so that they clearly understand the importance of making plan. They feel that, the plan will help professional carers to provide a person-centered care. And also they clearly feel that eliminate the confusion. But sometimes the people with intellectual disability, they acknowledge, and the family members acknowledge that some of the wishes cannot be facilitated at the end of life. So people have a good understanding about the importance of advanced care plan, but they need a support to make the decision. So in relation to communication, the people with intellectual disability, they have a right to be informed about the conditions. They decide to make the decision about their own care and what's happening around them. They strongly believe that knowing the prognosis helps to reduce their anxiety and frustration. They expect healthcare professionals to have an open communication and respect their choices. So these are the summary of the findings from my research. So this one, then I interested, then I recently completed a systematic review. Again, I focus on the perception of views of people with intellectual disabilities. So I really interested on the views of service users. So I included 11 qualitative papers that dealt with experience and perception of people with intellectual disabilities. From the findings, I developed a care framework. That is an important pillar for most people, most paper that I included that talk about the four important pillar, the people with intellectual disabilities that recur during the palliative and end-of-life care phase. Number one is communications. Number two, communication, they want the people to be open and accessible information. And people with intellectual disability, they want to have an autonomy during the palliative care phase. They can be able to make the decision and they want to make a control of what is happening around them. And also they talk about the relationship. They talk about the importance of certain important relationship and how the relationship can be maintained during the palliative and end of life care phase. Then talk about the environment. So they talk about the importance of familiar environment and unfamiliar environment. The communication, the most people that talk, the most of the papers, they talk about open communication. My doctor says that I should go and have a holiday. Well, I can. What does that mean? So the people are confused about the language, the type of that language, the indirect language. They want to have a straight language, you tell it straight. It's open and they appreciate the open and transparent communication. They don't like any affirmation. They want to tell us it is. And also the communication that the people are going to use is an accessible communication. They don't want any medical jargon, the simple and plain language. One size doesn't fit all. So as a professionals and carers, we have to be very pragmatic and creative to develop an information that is accessible for people with intellectual disabilities. Autonomy. In relation to autonomy, most people with intellectual disability, they feel that, they can make the decision. They are adult and they're responsible. So they can decide about what is happening around them when they live. And also they can make the decision about where they want to die, where they want to be cared, and where they want to be cremated. And also who they want to be around during the funeral. So they have an ability to make the decision, but the only thing they need is support. And also they want to make a control. Most people, they don't want to talk about the bad things all the time. They want to have a control of what is happening. They focus on good things. They want to make a plan. So they want to make a control of everything. Most of things, if possible, they want to make a control of what is happening around them. The relationship, they have a relationship net of parents and family and friends and carers. They feel, they wanted to maintain that relationship during the palliative and end of life care phase. They feel, they feel safe and comfortable when visited when they see by parents and family and have a chat with the friends and carers. They feel comfortable and safe. They feel that that they feel comfortable. They are going to be looked after well. So they want to maintain this important relationship during the palliative care phase. The environment, they talk about the familiar and, as they prefer to be in the environment that is familiar to them and the cared by the familiar carers, and also they be with the familiar people. So anything other than reflecting the home is not appropriate for them. And some people, some of the paper addressed that is some of the people with intellectual disabilities that acknowledge the importance of hospice, but they feel that that space is not appropriate for everyone. Some people, they feel they're isolated there, they're neglected, they feel they're neglected. So they want to be in the environment that is familiar to them and surrounded by familiar people. So what's the perspectives of families? Some of the families, most of the findings that shared by the people with intellectual disabilities are mirrored with people, family members. But in relation to communication, they differ. Some of the family members are okay to disclose the information to the person with intellectual disabilities. They're happy to share with her. But some of the family members are reluctant. They don't want to share the diagnosis with their loved ones. They want to protect them. They don't want to upset them. They fear that discussion about the diagnosis and prognosis may cause an emotional distress to their loved ones. So that's why they don't want to disclose it. And also they don't know how much the person with intellectual disability understand about the disease, how much they understand about the prognosis. That's why they're afraid to disclose it. So what our role as a healthcare professional? So we need to prepare an evidence, to open and transparent communication that is evidence-based, and also we have to provide an accessible communication that is understandable by the person with intellectual disabilities. We need to facilitate, we cannot and we should not make a decision for a person with intellectual disabilities, but we can help them and we can support them to make a decision. With the family and individually with intellectual disabilities need support. So we need to include the family members as much as possible in the care of person with intellectual disabilities. Whatever the care that we provide should aligns with the preference and wishes of person with intellectual disabilities. So what are the challenges? Just I want to share with some of the challenges during my research when I discuss about the sensitive topic, because this is a double risk, so when you research people with intellectual disabilities, a risk, and also when you talk about the sensitive topic, there's another risk, so some of the challenges experienced, the recruitment was challenges, some of the services, especially the residential services, that the governance and gatekeeping is difficult to recruit participants with intellectual disability for this kind of research. The service providers, so some of the carers and professionals, they still have a paternalistic attitude that led the people with intellectual disability to participate in this kind of research. They feel that it's going to harm them. And some of the family members, they decline to participate because they're concerned about their privacy. They don't want the service to know about the participation in the research. But however, so when I directly spoke with people with intellectual disabilities who lived in the community settings, that increase the recruitment. The ethical challenges, so when you take the box that, you're going to include people with intellectual disabilities, it became a high risk research. The ethics committee, they started to scrutinize the application. So I know that they're doing it for the goodwill. They want to protect the person, vulnerable population, but there's too much of restriction, and that maybe restricts the people with intellectual disabilities to participate in this kind of research. So if anybody wants to undertake a research with the people with intellectual disabilities, you need to block a good amount of time to prepare your ethical applications. And also you need a good bit of time to develop a accessible material about your research and consent form. And also you need an additional time to support this person with intellectual disabilities to make informed decisions. As any other research, you need an ongoing verbal consent. But and also you need, and also you need to an additional time to pilot your interviews. In case if you develop an interview schedule, you have to pilot. You have enough time to pilot with person with intellectual disabilities. A discussion sensitive, but I did not find any difficulties talking about death and dying or palliative care. The most people are enjoy talking about it, and they take a pride of they are going to contribute something for the future care. But the story, I found that storytelling approach from the book was very helpful when I spoke with people with moderate intellectual disabilities. But some of the people with intellectual disabilities, that they felt upset when they recalled the death of their friends. They become upset. But I gave them a time, and I stopped the interview. I gave them enough time to come back. Some of the people with intellectual disability, they wanted to continue the interview, but some of them, they wanted to stop. They are maybe then I continued the interview after 2 weeks. Some of the people, they wanted a follow-up visits, so just I wanted to check with them, how they're getting on. And also, you need to prepare for the disappointments. So maybe sometimes you take a time off and, you drive a long time and go to speak to people with intellectual disabilities. Sometimes they don't want to speak. Then you have to prepare for that kind of disappointment. So it happened a couple of times to me, so I took a time off, I drove, and when I go for the interview, then he refused. He didn't want to. Then, we had just a common chat. Then, that is the closer to Christmas. Then we talked about the Christmas. Then we went to a cafe. Then we had a coffee. Then I left. Then after 2 weeks, I went back again to have an interview. So you had to prepare for this kind of disappointment. So what are the implications for practice? You know, you have to acknowledge the preference and wishes of people with intellectual disabilities. So what are the care plan that you make that should be reflective of the wishes and preferences that include the holistic care, that meeting the physical, social, emotional, and spiritual needs? So there is a lack of, we have found that there is a lack of training and expertise between the two services. The palliative, professionals or carers who are working in the intellectual disability services that lacks the skills of providing palliative care. The professionals working in other care settings like, general health care settings or maybe in a hospital that lack the expertise of identifying and meeting the needs of people with intellectual disability. So it is very much important to two settings that work close and exchange their expertise and the training each other. They learn from each other. And thus the communication is the key thing, that all professions, irrespective of the setting, they need to have a structured communication to how to communicate with people with intellectual disabilities. So you need to encourage the family members. So some of you can see the different type of families. Some of the family members, they don't care about, even they forget their loved ones are exist. Some of the family members are very close. They're very much involved. So you have to involve them as much as possible. And also you need to develop an accessible care planning too. I think the Trinity Center for Aging and Intellectual Disability, they have a fantastic resources in relation to accessible advanced care planning too. I think you can use it and you can modify based on your requirement. And also every organization has to develop the policy to support the informed decision making of people with intellectual disabilities. To conclude, the people with intellectual disability, they want to maintain the normalcy. So they want to maintain the continuity. They maintain the routine. So just you facilitate as much as possible. And also people with intellectual disabilities, they want to be in a familiar environment. They felt that, that will give them a comfort and the dignity and emotional well-being. So facilitate this as much as possible. And also, so whatever the plan you make, whatever the care that you provide, just you respect their rights and respect their needs. But in relation to the research, the people with intellectual disability, they can meaningfully engage in the research and they can meaningfully contribute. The most often, the ethical protocol should support and not hinder the participation of people with intellectual disabilities. And if you develop a protocol, that is sensitive and inclusive, that is able to include all people with intellectual disabilities in your research. So before I conclude, I want to share a story with you about the importance of touching and being with a person, the being with a person who's dying. So Mary, her name, again, this is a pseudonym. She was 75 at the time. She has mild intellectual disabilities, but she was diagnosed with a severe dementia. You all know that the dying trajectory is not smooth as the cancer death. So this is going up and down for people with dementia. She had a couple of occasions. She really, she stopped eating and drinking and unresponsive for a couple of times. So we brought her friends and the carers who helped her in the past, and also we rang her son. And everybody was there, so we expecting that she was not going to make it. She was going to die, but she came back again. So she came back. It happens a couple of times. There's one time, she stopped eating and drinking and unresponsive, and her breathing changed. We thought that she's not going to make it. So again, we brought her friends and the carers, and I rang her son. He was at work. He said, Kumar, look, she'll be fine. She's going to come back. Look, I cannot come now. I will come after my work. And really, we fear, we all worried about whether he's not going to make it. Maybe around 6:30 he came in, and literally Mary was lingering, so she was lingering. And her son came in, and we left the room for her son and for Mary. And he touched her hand and he kissed her forehead, and he with her for maybe 5 to 10 minutes. He came out after 10 minutes. He told us she stopped her breathing. We went inside, she passed away. Then we started routine care. So why I'm telling the story is, no matter how cognitively they impaired, they understand the touch. They understand what's happening around. They know that they can able to differentiate the touch. They can able to differentiate who's around with them. So I highlight the importance of the touch and the presence of loved ones when somebody die. So no matter how cognitively impaired, it is more important to them. They can acknowledge, they can feel it, and they can see it. Thank you. Thank you for listening.